All right, so week 5 is all about infant mortality. What are the three main causes? You have, it's not focusing, there we go. Preterm births, perinatal conditions essentially, congenital abnormalities, so maybe macrocephaly or large head, which could lead to cerebrospinal fluid buildup or something essentially that is going to cause an abnormality in function. So it could be a heart abnormality, could be really anything. And then SIDS, which is sudden infant death syndrome. In terms of primary versus secondary maternal mortality, secondary is always secondary to something. That's the best way I like to think about it. So maybe you already have cardiovascular problems, so you would have maternal mortality as a result of having this cardiovascular problem, not really to do anything with the pregnancy. So non-pregnancy related bleeding, this could happen in the gastrointestinal tract, and you could have a non-obstetric hemorrhage, which is just an hemorrhage that is not due to the pregnancy, essentially. That's the simplest way that I can describe it. Thromboembolism, this is blood clotting. You could have amniotic fluid embolisms and hypertensive disorders. What's an embolism? Essentially just a piece of, it's either like an air bubble or a lot of clump platelets or dead cells that are just traveling along the artery. They maybe get clogged in a capillary. Now that tissue is starved of oxygen, or they can go into the head, rupture a blood vessel there, causing a stroke. This could lead to more bleeding and death. So that would be a primary example because it's related to a pregnancy-related clotting. Remember, pregnancy is a hypercoagulable state. You'll learn more about that next year. Essentially, it means that there's higher chance of getting clots. Clots can break off and they can cause damage. Now, why has maternal mortality decreased? So we have screening, we have vaccinations, child's spacing, so not having children right after each other, breastfeeding, living standards, and then antibiotics and medical advances. Maybe try to explain like what does screening actually mean, what would be an example of screening. An example would be the heel prick test, for example. And then antenatal care is just before birth care. So this could include education, delivery planning, such as when they're going to come to hospital, how that process is going to be looking like, checking fetal position. This will be covered in repro. You essentially want the head facing the vaginal canal. You can offer folic acid to the mother. This will be covered more in year 2, but if anyone's interested, it's just because folic acid helps with DNA replication and helps with red blood cell production. So you want to also manage any pre-existing conditions, so hypertensive, any respiratory related illnesses, diabetes, because it increases blood sugar, asthma that can limit oxygen, which could cause growth abnormalities in very extreme cases. So you want to manage all these pre-existing conditions. Now you have postnatal care, which is basically after birth care. That's the best way that I can describe it. So good postnatal care will result in quicker discharge. You don't want someone to be in the hospital for no reason, for a multitude of reasons. You just want to get them out of there as quick as possible. There could be financial reasons for that. It's not financially good if people are staying in hospital longer because it increases healthcare costs. But there's also other reasons, such as the hospital is, I don't know how to say it. It's usually not like the best place to be just hanging out. You could have stress from being in the hospital, lack of country. You could have maybe, I guess it's clean, but you could still have germs and whatnot. And at the same time, it's also like a psychological thing that you kind of just you don't want to stay there if you don't have to. Now you also have the heel prick test, and specifically this is going to screen for PKU, so that connects into GH, hypothyroidism, cystic fibrosis, and galactosemia. Now the midwife will actually contact the mother in 10 days, and you also have a formal postnatal check at 6 weeks postpartum. And what we're going to check is we're going to check for growth, feeding, congenital abnormalities, and vaccines. And I'm going to talk a little bit about fetal alcohol syndrome defects. So we're going to be checking for vision. We can look for epicanthal folds, which are kind of these like flattened folds, most medial to the eye. Weight and height, social development, gross and fine motor skills, and then not looking for head circumference. So they might have microcephaly, which is a small head, but this is not related to fetal alcohol syndrome. And I think that was there was something that they highlighted in the slides. So just keep that in the back of your mind. Now, again, people with fetal alcohol syndrome can have thin upper lips. They can have epicanthal folds. The reason why it's really hard to diagnose is because there's a lot of stigma, as you essentially have to criticize the parents and even bring up the concept that they had drunk alcohol during the pregnancy. And the harsh reality is no one wants to admit that, even if that is the case. So the reason why we do want to diagnose it, though, despite having the stigma that could arise, is that we can organize access to special schooling, and then we can create special understanding of the child's needs. And that was covered in the GLS.